Assalamu alaikum, learned chairpersons, panelists, and learned audience from home and abroad. My talk is on upfront to stent strategy, how to optimize case-based practical problems and solutions. Practically, we have seen 3 lectures, and my lecture is 70% covered. So I shall go forward, and those whose part is covered, I shall not repeat that. But like bifurcation lesion, there are different definitions, out of which some definition we must have to recapitulate. Lesions occurring at or adjacent to a significant division of a major epicardial coronary artery. And there is true bifurcation, non-true bifurcation. This has been shown by Professor Saidur Rahman. And this classification is also well-known classification, already shown. And this is very important slide. When I need a double stent strategy, bifurcation treatment strategy, if I think that side branch should be preserved, then what should I do? And if I think whenever side branch should not be preserved, side branch may not be preserved, then PCI of the main branch. And if side branch should be preserved, then think whether likelihood of the side branch will be jeopardized or not. If there is likelihood of jeopardized of the side branch is not, then provisional stenting and wire the side branch, recross, and if necessary, second side branch, if there is side branch compromise, then side branch balloon angioplasty, KBI, and if there is significant compromise, then we shall have to think side branch angulation. If the angulation is less than 70 degree and more than 70 to 90 degree, if more than 70 to 90 degree, we shall have to go for any crash, either decay crash, crash. And if we come, the likelihood of the side branch occlusion is high, and then we shall have to think the plan to stent strategy. And in that case, we shall have to think the angulation of the lesion 70 to 90 degree and less than 70 degree. If the level less than 70 degree, we shall have to go for different types of crash, decay crash, culotte, and if 70 to 90 degree, then T or TAP. There are guidelines for the treatment of bifurcation lesions. In 2018 ESC, ESCT, if we see, this has been also discussed, but as because guidelines, so I like to tell, provisional stenting should be the preferred approach. Professor Saidur Rahman has shown, and exceptions to this rule. When I take the necessary action for double stent strategy, he has also shown it, side branch dia and side branch length of the lesion and anticipated difficulty in accessing the side branch and through distal left main. And EBC main, this trial, and also they have told here, one thing I like to tell, that whenever I anticipate the side branch loss, and that a loss occurs due to carina shift, plaque shift, dissection, or spasm. And these are the different scenarios of the bifurcation lesion. And regarding the side branch length, it is very important. If you see, if the side branch length is more than 10 millimeter, then cardiac death, target vessel myocardial infarction, target lesion myocardial revascularization, target lesion failure, and stent thrombosis, all are more. And side branch length in different studies, they also showed that more the side branch length, more will be the complications. And definition 2 study, this slide also shown by Professor Saidur Rahman. Here I like to say only, and when we shall have to consider double stent strategy, if we see the features on plus sign on the right end picture, there's a moderate to severe calcification, multiple lesions, and active thrombus, bifurcation angle less than 45 degree, main branch reference diameter is less than 2.5 millimeter, and main branch lesion more than 25 millimeter. All these scenarios includes complex bifurcation. And whenever complex bifurcation, only then we shall have to think upfront double stent strategy. And this has been already shown by the previous speaker, that if there is simple bifurcation, then the result, that is the longevity without target lesion revascularization, is in favor of professional stenting. And 1 year death-free survival, meaning that 1 year survival, if complex bifurcation lesion, two-stent strategy is beneficial. And definition 2 study, they have already shown you in one sentence. If I tell, then last slide, this slide, you see target lesion revascularization, target vessel myocardial infarction, target lesion failure, all in favor of double stent strategy, provided this complex lesion. And there are different strategy for lesion preparation. And recommendation on functional testing and IBUS for lesion assessment. Usually for bifurcation lesion, complex bifurcation lesion, intravascular ultrasound or OCT is essential, though it is class 2A indication. Percutaneous coronary intervention with or without intravascular ultrasound. If we see the data is in favor of intravascular ultrasound, but if we see the study definition, EBC main, only 20% of the 22% of the patients required second stent, and in the complex arm, around 30% patient required intravascular ultrasound. And use of intravascular ultrasound, in particular left main bifurcation, we usually prefer it. And regarding bifurcation stenting, as we know that bifurcation stenting, there are different techniques, out of which simple stenting, bifurcation lesion strategies, and complex stenting. Complex stenting like decay crash stenting, and there also be T stenting, modified T tap, and culotte. Nowadays, we also like DK culotte, and even later on, we have reached DK mini culotte. Operator experience does matter. It should be very important that operator should be confident enough for the system. That is the, whatever may be the strategy, either decay crash or culotte, decay mini culotte, whatever it is, it should be operator's choice with anatomical features and his expertise. And usually we do upfront study, vessel is more than 2.5 millimeter, side branch, and we have already told side branch lesion more than 10 millimeter, or somebody tell more than 5 millimeter, unfavorable angle and dissection of the side branch. And these are the features when what are the procedures we can do. And EBC recommendation of using upfront two-stent strategy, technique 16th consensus. A planned two-stent technique may be indicated for bifurcation with long side branch lesions, difficult side branch access, or high risk of side branch compromise. Vessel anatomy, vessel size, need for stenting the side branch first, and operator proficiency affect the choice of strategy. And recommended techniques included, we have mentioned already, and POT is recommended and ensure optimal stent expansion in both main branch as well as side branch. And virtually, this is my talk, how to optimize the double stent strategy. And always finalize a double stent procedure with KBI followed by a POT, and POT should be ideal. 16th consensus EBC highlights in the potential pitfalls. There are different pitfalls, as we know, for the bifurcation lesion. Even then, for the double stent strategy upfront, even then, whenever it is necessary, we must have to do. And evaluation of the different strategies, if we see the evaluation, then different platforms, different designs, and more appropriate strut thickness and cell opening for use in bifurcation, and more detailed data coming from bench testing and clinical practice regarding double stent strategy, more use of intravascular imaging for procedural success, and more effective devices for calcified lesion, for lesion preparation, and improvement of the basic strategies, and more clinical data with improved outcome is coming. And these are the different steps of the different types of intervention. That is, this is the TAP technique. I do not want to go for every step. And I like to tell the basic important thing. What are the advantages of TAP? Relatively simple and assures osteal coverage and less metal at the side branch osteum compared to any types of crash. And disadvantage requires very precise placement of the stent in the side branch. Excessive stent protrusion cause main branch access problems later, and balloon deflation in ABI should be mandatory simultaneous. It is one important point, both the balloons simultaneously inflation as well as simultaneously deflation, otherwise carina will be deformed and might be more difficult to treat restenosis. This is another disadvantage. After decay crash or whatever may be the double stent strategy, if patient comes with restenosis, that is really a challenging problem. And this is the culotte, and we know the different steps of the culotte. I shall show in case, and that is why theoretically I do not want to tell too much. These are the different steps. Let us see cases. 65 years, male, smoker, diabetic, non-ST elevation, myocardial infarction, and left ventricular ejection fraction 47%. And you see, this is the angiographic findings. LED diagonal bifurcation, both LED as well as diagonal branch. Osteoproximal part is significantly narrowed. You see in this yellow caudal view, it looks good, and right coronary is normal. And then CAG revealed double vessel disease with LED D1, Medina 111. And what should be the next plan? Provisional single stent strategy or upfront double stent strategy? As because the side branch osteoproximal lesion extended from the ostium up to 10 to 12 millimeter or 15 millimeter, that is why we have decided upfront double stent strategy. You see, we are wired both the vessel, and we have done the IVUS from diagonal as well as from LED. LED dia is 3.93 and osteal diagonal is 2.88. And we pre-dilated both the lesions, diagonal, then LED, then LED to diagonal stent placement and stent deployment. And after that, recross port is done. After port, recrossing and first kiss. And after first kiss, second stent LED over diagonal is done, 3 into 48 millimeter. And then port is once again done, and then recrossed and second kiss. And after the second kiss, report done. And this is the result after. This is the result after the final port. On the right, port is done. And you see the post stent IVUS on the left side, left panel, 15.09 LED dia, and on the right panel D1, 6.93 osteal dia, proximal dia. And this is the final result. And we have done this by DK culotte. And these are the different steps of the DK culotte. I do not want to go through all the steps of the decay culotte. One thing, this Ben's study means decay culotte as study suggested that the double kissing strategy can significantly improve the performance of the culotte technique. That is why decay culotte has appeared. And these are the next case. This is another patient having LED diagonal lesion 111. Here you see diagonal is also critically ill, and here we have decided to do a decay crash. And we have wired both the vessels, pre-dilated both the lesion, and diagonal stent deployment, placement of the stent in the diagonal, deployment of the stent in the diagonal, and crossing the first crash is done. And following that, first kissing on the left panel, and then on the right panel, the LED stent is deployed, and port is done once again, and then recross, and here kiss is done, and after that report, and after the report, this is the final result. And sometimes we also do mini crash. This is a bit simpler than decay crash or culotte, and we see in practically step by step, not theoretically, then it will take time. You see, this is another case that is LED diagonal, and both the LED as well as diagonal have critical lesion. And so we have decided to do mini crash. And both the preparation of the diagonal as well as LED lesion is done. And then LED diagonal stent is, placement of the diagonal stent is done. And port is done. And this is the final result. Professional versus several steps has been omitted for time. And professional versus double stent strategy. Professional strategy is superior, but whenever double stent strategy is needed, it is superior at that time for that particular patient, for that particular performer. And double stent broadly, there have been a series of randomized controlled decay crash trials, and decay crash has the superiority over all other double stent strategy. And these are the different. And if you see professional two-stent technique for bifurcation lesions in second generation drug-eluting era, they have shown the superiority in all aspects of double stent strategy. And there are various pros and cons. I don't want to tell that. But the take-home message, the professional stenting is still the gold standard and performed in 70 to 80% of all the bifurcation lesions. Upfront two-stent strategy based on side branch, clinical relevance, and lesion characteristics sometimes mandatory. Appropriate patient selection, operator skill, proper technique, and image-guided PCI proved clinical and procedural outcome. And more attention should be paid to optimizing the chosen technique than to choose among the techniques. And decay crash is valuable option for suitable complex sets of bifurcation lesions according to definition 2 study criteria. And from recent refinement, some procedural steps on side branch optimization, sequential, and step up balloon inflation for complete side branch crashing, proximal side branch struck crossing, port, report after main vessel stenting, after correctly performed final kiss is the key to success. Thank you. Thank you.